All right, good morning, everybody.
Wow.
Hi, I'm Diane
wow.
Birnbaumer. I work down this, well, actually kind of down and around the corner here, about a 45-minute drive away, at one of the county hospitals in LA. Sanjay and Mike Minchin, who you'll meet tomorrow, work at Big County, which is LA County, USC. I work down at Harbor UCLA, which is Little County, which is basically a volume of about a little less than half of what they have, and pretty much the same patient population. So it's an LA County hospital with everything that goes with that, including all of its dysfunction. And when we talk about ED crowding, we'll talk about sort of the issues that come up in county hospitals in LA. But that being said, let's start with shoulders. So this is actually kind of fun. This is page 105, I believe, is in your book. And I'm going to do a little bit different than what's in the book for you. I'm going to rearrange the order a little bit because I think a little differently than Kevin Clower, who wrote this chapter, thinks. So I'm going to reverse the order a smidge. And honestly, you don't even have to flip to any pages if you don't want to. We'll just talk about shoulders. And this is not, shoulders kind of fall into two major categories. I'm working PM shifts all this week, and yesterday, when you walk into a shift and the place is gonzo and there's a bunch of screaming crazy people and there's a bunch of vague, dizzy people, and it's just so refreshing to see pop up on the screen shoulder dislocation. It's like, I know what happened, I know what to do about it, and depending on my mood, I can fix it about 50 gazillion different ways. It's totally fun. Love that. We're not going to talk about that. We're going to talk about other kinds of shoulder disorders. So first and foremost, I'm amazed at the human body. Every time I work a shift, or every time I really sit and think about it, we are a remarkably complex organism. And the fact that anything goes right amazes me. There's a bazillion things that can go wrong. And the fact that most of it goes right most of the time is really, truly remarkable. And if you really think about how the motor function, or actually our kinesiology function works, the shoulder is an engineering marvel. Marvel. Have any of you guys ever seen that sort of bodies in motion, the plastinated human bodies that they've redone? I highly recommend, if you ever get a chance, wherever you happen to be, if that comes to town, or if it's a permanent exhibit, which I think it is in like New Orleans, or not New Orleans, in Las Vegas, what they've done is they've taken human cadavers and done a process called plastination, where they basically embed all of the structures with a polymer that becomes hardened, and it basically takes what you are and makes it permanent. And what they've done is dissected out bits and pieces of people and doing all kinds of cool stuff, riding a bike, swimming, and they'll cut it down the middle so you can see all the parts and how they work. And one of the things that is amazing to look at is the shoulder. Think about what your shoulder is, and then think about what it does. Your shoulder is one skinny little bone sticking out into space, and then one flat bone with a couple little thingies that stick out and a little cup hanging in the back. And then hanging in the middle of that is a round ball bone. And the way that thing is structured, with all of the cantilevering that occurs and all of the ligaments and all of the muscular structure, think what you can do with that shoulder. Let's see, I want to scratch my back here. Oh, let me put my hair up here. Oh, wait, I want to reach over here and do this. Oh, I'm going to grab something up here. Oh, let me reach down here. Oh, let me lift it up and push it over there. Incredible what your shoulder can do. Absolutely remarkable. That being said, a lot of things can go wrong with your shoulder. And over time, especially as you use your arms unbelievably. Let me grab something in the back. You use your arm structure tremendously. I'm sorry about the video, but I'm going to grab something. Rick, let me grab something here. That thing in front of you, the cloth, this. So your shoulder is really, really important. And the thing about it is to understand, for those of us that work in emergency medicine or even office-based, is what can go wrong with it short of trauma. Now, traumatically, you can do anything from break a bone to dislocate, but often what you can do is tear your rotator cuff. The pictures kind of 2/3 of the way through this chapter show you how that shoulder is put together. And the major muscle structure that holds it together is your rotator cuff. That has 4 muscles in it, and it's the sits muscles, okay? So you get your supraspinatus, your infraspinatus, your teres minor, and your subscapularis. The supraspinatus is the most important muscle of that group. And what it does for you is it allows you to take your arm from your side up to 90 degrees. That's what your supraspinatus does. And if you think about how that is put together, it makes complete sense. It is not what gets you from here to here. This is your deltoid. And if you think about how your shoulder works, your deltoid wraps over all those sits muscles, and it makes sense that it gives you the extra bit. It makes total sense that your rotator cuff, which is internal, it's part of the capsule itself, can only get you this far, right? To get it up, that's as far as it can go because that's where it's attached. To get you higher than that has to be your deltoid. It makes total sense that that's how that works. So your supraspinatus goes to here. Now your infraspinatus and your teres minor allow you to externally rotate. Okay, that's what they allow you to do. So if you wanted to isolate those the best you can, is you basically take somebody's elbow at their side, so you're not involving the supraspinatus at all, and you externally rotate their shoulder. That's what those two muscles do. Your subscapularis allows you to internally rotate. A great way to test that is to have someone put their hand behind their back. You have to be able to internally rotate, put your hand behind your back. You need to understand how those functions work so you have some idea of what's been damaged when somebody has a shoulder injury or shoulder pain, what's causing the trouble, which then leads you to the idea of how do you examine a shoulder. There are a couple, I'll tell you, these days, if I have a resident that doesn't know how to examine a shoulder, I pop up YouTube and I have them look at the University of Wisconsin's shoulder exam video. Google shoulder exam video. Just put it in your Google search engine, shoulder exam video, and two things are going to come up. One is the University of Wisconsin's, I believe, family medicine program's shoulder exam. It's an 8-minute long video, fantastic video. The second thing that comes up is the McMaster video, which is shorter. It's about 4 minutes long. Both of them are wonderful at showing you a good, thorough shoulder exam. The problem for us, at least in the emergency setting, is to truly isolate all the little bits and pieces of the shoulder takes a long time to do a really, really good exam. So what you need is sort of a curtailed exam to have some idea what's wrong with the patient that involves the basics. So, for instance, what you want to do is look at the patient's shoulder. The way the patient holds themselves, it's not just the step off. We all look for the step off, hoping for that dislocation because that's the fun thing. But look at how somebody holds their shoulder. People with shoulder pain often will hunch forward a little bit and internally kind of rotate forward. It's called a hunch shoulder look. They'll actually sit sort of like this because that is the position that's the most comfortable and neutral for your shoulder, is rounding your shoulders forward a little bit and rotating your shoulder forward a smidge. That's the most comfortable position with an acute shoulder injury or chronic shoulder pain. So look how they're positioned, observe them. Then you're going to palpate, but I'll tell you the problem in the acute setting of palpation, in fact in any setting, is that it's difficult to isolate specific structures. As an example, the most commonly painful shoulder, non-traumatic shoulder problem involves the supraspinatus muscle. Okay, that inserts on the lateral aspect of your acromion. You can feel it's right there. Right below that is your deltoid bursa, your subdeltoid bursa. When that's inflamed, that whole area can end up being sort of tender. It's a little hard to isolate which is which. It's still worth doing the exam though, because people who complain of shoulder pain, you're going to want to do things like feel the biceps tendon. Is it actually biceps tendonitis that's causing their trouble, not truly the shoulder joint itself? It's actually the biceps tendon itself. So you're going to want to palpate, basically kind of getting an idea of, is it really just up here that's the problem, which is very common? Is it more in the front and it's more painful with this? That's actually a totally different issue to deal with than a true shoulder problem. So you want to do a good palpation exam with the understanding that some of it's limited. Okay? If it's supraspinatus or subdeltoid bursa, sometimes it's hard to tell, but it's worth doing. And then you want to do range of motion. The thing about range of motion, and everybody has their sort of favorite tests to do, and honestly, if you go to this video, or better yet, look at Wheeler's textbook of orthopedics, there are 8 gazillion tests you can do to test the shoulder, a gazillion. What you really want to know is, are any of those structures damaged and non-functional? That's the main thing you want to understand, so you have to do a couple of things. Remember what those muscles do, and test it. So have the patient abduct their arms to 90 degrees. Okay, if that's painful but they can do it, they have probably inflammation or a partial tear of the supraspinatus. Okay, this. If they can't do it at all, then you want to do what's called the drop test. So it's like, I can't. Okay, what you're going to do then is you're going to get them up here. Now your deltoid is involved, right? My deltoid is holding me up here. I'm going to do what's called the drop test. I usually keep my hand underneath theirs. They come down, they come down, they come down. If they hit here and it does this, they have a tear. They can't hold it up anymore. They have a tear. Again, deltoid, 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 supraspinatus. Okay, so this is what your supraspinatus does. So you're going to want to basically do this. Remember that your infraspinatus and your teres minor externally rotate. And the most comfortable position to do that in somebody's having acute pain is keep their elbow at their side and externally rotate. That's all you need to do. Okay, does that hurt them? Internal, and then internal rotation, if they can actually reach here, they're good. If they can't, then put them at neutral and have them internally rotate against resistance and see if that hurts. Again, what you're trying to do in a quick study in the emergency department is figure out, is there one muscle that's hurt? Is it truly torn? They have a drop test, it's torn, it's a big deal, or it's just inflamed and it's causing some trouble, or it's a partial tear. Your job is really that in the emergency department. So I hurt my shoulder about a little over a year ago. And I wish I had some dramatic, wonderful story to tell you how I did it, but I did it turning the compost bin. I was out composting, I was rotating our compost bin, I pushed it really hard, and I dropped to my knees. It was like somebody shot me in the shoulder. So I tried to baby it, it just didn't work, nothing. So I went to finally see an orthopedist. You know what his exam was? He didn't, so I'm literally dressed like this in his office. And he comes into the office, and this is somebody I knew through someone else. It's like one of my graduates had trained with him. I went to see him. He's our local shoulder guy. He's got a shoulder, fellowship, and he does all the shoulders in our area, and he's the shoulder guy. So I thought, great, I'm going to go see the pro. His exam consisted of, I was sitting on the table. He said, okay. He said, raise your arms up like a touchdown. So I did this because I couldn't raise my arms like a touchdown. And he said, oh, great. What did he do? What did he do? Come on, what did he do? He ordered an MR, which happened to be, oh, by the way, in his little fiefdom. So they have an MR, they have a physical therapy, they have their surgery center, and they have their offices. It's like this little pod of money-making churning right there in the South Bay. And that was I got so ticked off, I said, honey, really, seriously? Really? It's $450 now just to stand in this room. At least have me take off my jacket and do a quasi-exam. So he kind of sighed. He came over and he did a little palpating around and kind of looked at it, and he made me do a few more things. He said, MR. So I was right back to getting my MR. So that's what the orthopedists do. But the reality is our job really is to determine, is there something that acutely needs any kind of see you tomorrow kind of visit? And honestly, the reality is no. There's very few things that are either atraumatic, not direct trauma injuries that you really need somebody to see anybody special today for. So our job is to try to figure out, is there anything that I need to do acutely for this person? And usually the answer is no. Then the issue that comes up is, what kind of imaging do we need? Now, there are abstracts in here that look at plain films. And I will tell you, in the atraumatic shoulder, or the non-direct trauma shoulder, you rarely, if ever, need plain films. What you may see on plain films, especially if it happens to be an overuse syndrome, often in women, is calcific tendonitis. That's all interesting. It still doesn't change a lot of what we do, but you may actually see calcific tendonitis, but it doesn't change a lot of our approach of what we do for the shoulder, so it doesn't change a ton. And if you wanted to learn a lot about plain films, there's a whole bunch of abstracts in here about it, but did you know there's a Zenka view, a West Point axillary view, a Stryker notch view, a Bennett's view, a Garth anterior apical oblique view? The reality is, if you really want to see bones, you need two views at 90 degrees to one another, and then if anything looks funky, something oblique-ish or angled-ish to get another view of what you're looking for. Honestly, that's all there is in plain film, no matter what part of the body you're looking at. Basically, two orthogonal views, 90 degrees to each other. And then if that doesn't give you the information you want, get some tweaky views sort of beyond that. But plain films overall are not particularly helpful for us when it comes to acute shoulder injuries. What do we usually do? What do you usually refer them for? What do my orthopedists do? MR. How good is MR, really? It's sort of the standard. How good is it? There's a great paper in here. Abstract number 14, just so that you have some idea where it's coming from. Abstract number 14 is a really good study. They basically get 65 studies in a meta-analysis, and what they did was wonderful. They only pulled papers where the gold standard of a rotator cuff injury, a true damage to the rotator cuff, the gold standard was surgery. A surgical identification of a surgically amenable lesion. Perfect, beautiful. Then they went and they looked at MR alone, MR with arthrography, or ultrasound to image the shoulder. What they found is the best study was MR with arthrography. That being said, it still missed anywhere between 9 and 15% of surgically amenable rotator cuff injuries. Kind of interesting. MR itself, MR alone, was a little bit less, but it was equal to ultrasound in the right hands. Now, ultrasound, I tell you, ultrasound is, and Sanjay has his feelings about ultrasound. We talk about this on the panel, but ultrasound is taking over a whole lot of things in how we image. And what I'll tell you, give you one guess who's gotten really, really good at doing ultrasound to diagnose shoulder stuff. What group of practitioners? Say it again? Physios, absolutely. So chiropractors and physical therapists, and chiropractors in particular in the United States, have gotten very good at this. They've taken courses. They are just as accurate. In the right hands, ultrasound is just as accurate as MR in getting somebody imaged. It's cheaper. It's quick. You can follow it easily as people go. This is for rotator cuff injuries, and it's really quite good. So just know that out there in the right hands, if you have somebody who's good at ultrasound, they're just as good as an MR at picking up surgically amenable lesions, things that we care about. So ultrasound is actually quite good. Abstract number 13 looks at that. Wonderful as far as additional help in diagnosing rotator cuff injuries. It's absolutely fabulous. All right, if we have an injury, how do we treat it? Abstracts 7, 8, 9, and 10 look at this. And I'll tell you sort of the take-home message on these. One, non-steroidals help some. It turns out that they're not great, but they help some. 2, steroids may or may not help. There's an abstract in there that shows basically abstracts 6 and 7 are probably the most helpful in this particular discussion. Abstract 6 looks at using steroids. And steroids compared to other things, steroids compared to physical therapy, steroids compared to non-steroidals. And a couple of things come out of that paper. In virtually every comparator, steroids have an efficacy benefit of either minus, about 10 is the lowest, to plus 20 over whatever the comparator is, which means none of them work well. Anytime you end up with a comparator where you get a minus, means that none of what are being compared to each other work particularly well. Okay, and if it goes from a minus to a plus, nothing is outstanding compared to something else. So that's one of the things to take home about this, is that physical therapy, non-steroidals, and steroids, none of them have a tremendous effect. That doesn't mean that an individual patient may not get a benefit. The other thing about steroids, the idea is, after a while, my orthopedist injected my shoulder with steroids, which is, you gotta be careful with that. It can cause some long-term trouble with injections. There's all kinds of potential downside. But if people are having a lot of trouble, the temptation is, well, let's squirt the juice in there and take the inflammation away. There's a paper in here I absolutely love. So first of all, they looked at 2 papers. One looked at where does the steroid go? If we're injecting a joint, and I'll tell you, shoulder joints are really easy to get into. It's one of the easiest joints to get into, especially if the shoulder's out. But even if the shoulder's in, it's pretty easy to get into. But they looked at where the steroids actually went when people got steroid injections into the shoulder, and about a third of the time, they never made it into the joint. Okay, never got in the joint. So that's point number 1. Point number 2, they did another study in here where they did ultrasound-guided shoulder injections. So they were sure they were in the joint. They watched it go into the joint, which is great. But what they did about that study that I love is they did, basically every patient got 2 shots. They got an ultrasound-guided shot into their shoulder, and they got a shot in their butt. Half the patients got steroid in their shoulder and saline in their hiney. The other half got steroid in their hiney and saline in their shoulder. Exactly the same outcomes. So the question is, does it make a difference where the steroid is? It's just that you have a steroid on board, which could even make the argument of oral steroids might have some potential benefit, but there's no studies that I can find on that, looking at oral steroids. So a couple things about steroids. They are sort of the last-ditch effort. You start with the non-steroidals and see if that works. Physical therapy has its own detractors and champions. Physical therapy is a relatively benign thing to do. And steroids do need to wait to see if people aren't better. And what every study says is that no matter what you get, and virtually no matter what the injury, except for a total tear, you are out function-wise for a minimum of 7 weeks and some people as long as 6 months, no matter what. So one of the things to tell somebody who has an acute shoulder injury or comes in with shoulder pain is that you're going to be in pain for weeks. It's not going to go away tomorrow. There's no magic that's going to take this away. Physical therapy may work, we'll try that. Non-steroidals may work, we'll try that. But just know that this is going to be a while before you're back to normal. The other thing for those of you in the room that are carrying your AARP cards, I am, and how they manage to get in your mailbox on your 50th birthday, you get your application. I still don't know how they do that. That is the most remarkable, honest to God, 50th birthday, it's in your mailbox. If you're over 50, your likelihood of a rotator cuff problem skyrockets. Again, it's use. You've done a lot with your shoulders for a really long time, and if you are having trouble sleeping because your pain keeps waking you up, you roll over on that side, you wake up. If you have pain when you're doing this, okay, it is highly likely that you have a rotator cuff, probably tear, to be perfectly honest. As you get older, you tear it without any obvious trauma that does it. That's a problem. And eventually, you may need to get your ultrasound. You may need to have it repaired. Eventually, that may be what you need. My experience was that physical therapy did wonders for me, and I did get non-steroidals, and I did get steroid injection, and it finally worked. But one of the things that came out of all of that is that I've been reading about and talking to people about immobilization. Because one of the things I did for myself, which was totally stupid in retrospect, is I didn't use my arm. That turns out in the lawyerly circles to be a wonderful reason to sue you. So if you take care of somebody who has a non-traumatic shoulder problem and they have pain, you don't want to immobilize them because what you get is adhesive capsulitis. It's very painful to move your shoulder, so you just don't, and you don't, and you don't. And the longer you don't, the less likely you are to ever get function back. And eventually, you lose it completely. So as a treating person and somebody with a shoulder problem, I not only don't give them a sling, I discourage their trying one at home because people can just go buy it in the grocery store and buy it in the drugstore. So it discourage their use and tell them to do Codman's exercises, which are basically the bend over and make circles. Okay, you're really putting no strain on the joint at all. Have them just make pendular circles of their arm because that will at least keep it mobile, and that is crucially important to do. Once you get adhesive capsulitis, it's game over. Taking you to the OR to try to break it up while you're under anesthesia doesn't work very well. It really, truly is game over. And if you've ever tried to use a shoulder that's damaged, it's a big problem. Try putting on scrubs. Think about it. Scrubs are a torture device to try to get into. Right, you got to put your arms together and then get up in the scrubs and do this. And so I'm supposed to wear scrubs to work. So just to wrap up my lecture, I'm supposed to wear scrubs to work with my name on it. But I had all these scrub shirts so that I couldn't even get into it. I couldn't even brush my hair. My poor husband, I couldn't brush my hair. I couldn't dress myself. It was a nightmare. So blessed, wonderful man that he is. My husband is the greatest guy ever. I go to work one day. I was all bummed out because my shoulder was terrible and I couldn't put on my scrubs. And I come home and he'd done this. He'd gotten my scrubs and he'd gone to an alterer and he put a zipper down the front of my scrubs. So my scrubs, now it turns out this is quite the fashion statement. The nurses love it. Absolutely. I figured I may have just found my golden parachute. Is zip up the front. Seriously, this may be how I retire, is this zip up the front scrub shirt. So the reality is, be careful with shoulders. Know how that works. Know what those muscles are. Know how to do an exam with the understanding that we may not find the exact injury today. Plain films aren't helpful. Ultrasound in the right hands is great. Neither ultrasound nor MR are things we're going to usually order acutely. Don't immobilize. They can try non-steroidals and physical therapy. Steroids come later, and tell them it's going to be 7 to 8 weeks minimum before they start to get any sort of reasonable function back, because that's just what happens with your shoulder. Okay, questions?